All right. Hello, internets. Welcome back to the Onco Data Podcast. We've been a little hit or miss over the summer. Everyone needs to take a little bit of time off, so it happens to the best of us. But we should be back on track coming into the summer's almost behind us. So we're back on track today and wanted to talk a little bit about ESMO GI. So I guess it's about 2.5, 3 weeks behind us, but we haven't had the chance to chat on a high level about some of the important findings coming out of that conference in Barcelona. So to that end, kind enough to have Dr. Akkus join me here today. And as I always like to do, we have never met prior to joining live on the podcast. So both for the audience and also for me, sir, if you wouldn't mind giving an introduction to yourself, your background and your interest in the GI space, and we can chat from there. So thank you very much.
Yeah, sure. Thanks so much for your kind invitation. So I'm Erman Akkus from Ankara University, Faculty of Medicine, Department of Medical Oncology from Turkey. I'm focusing on GI cancers, and now I'm happy to talk on ESMO GI 2025.
Wonderful. So I hate to be a salesperson, but since it's been a couple weeks, I think I might throw up on my screen in the context of ESMO GI, what we do with CLIN, especially focus on our conference coverage. And so I'll start there. I'll just share my screen real quick, just as a reminder to the audience. So this is what we have in LARVOL CLIN with respect to ESMO GI. It's actually exciting. We have a new interface here where we pull all of our analytics together on social media reactions from oncologists to the disclosure. So what you're seeing here is a summary. Right now, we've actually changed it to be ordered by views. So you're seeing all the most viewed X posts, the artist formerly known as Twitter. You're seeing the most viewed X posts from oncologists reacting to disclosures, in this case, Talentase, Panova, Matterhorn, and you can go all the way down and expand these analytics as well to the the long list. Obviously, we have a number of different analytics, which if you follow us on social media, you've probably also seen as well, in terms of the top oncologist influencer posts, and even how people are reacting based on the sponsor of the trial, and even individual oncologists matrix in a matrix versus the individual trial. So this is sort of the social media element of CLIN. Obviously, LARVOL CLIN has a lot more parts, including data analytics, including outcomes extraction. But we apply AI to have all of these reactions and also apply the sentiment so that you can see how oncologists are responding in a positive or negative fashion. So we could certainly delve into individual trials, but maybe where I'd start out, yielding back to my expert guest, is any themes, Dr. Akkus, you're seeing that really stood out to you from ESMO GI collectively, and then maybe we can explore a couple of individual trials.
Yeah. Sure. So first, the oncology is about data in the modern area. So you are doing great, I think. So first, thank you so much for your all efforts. So I think ESMO GI is becoming one of the leading congresses of GI cancers. So this year, approximately 4,000 participants went to the Barcelona for this congress. So it's full of data and discussion, I think. So when I try to talk about the data presented newly and in the original studies, beside educational sessions, so I can separate the topics and trials in some subsections. So one is that the ctDNA. So it's becoming a routine tool in daily practice, and we have seen ctDNA use in surveillance of colon cancer. And the other thing is that so we know that the overall survival and quality of life is the main endpoints that we can try to achieve. So we have seen a lot of data on quality of life of the major studies in ESMO GI. And the other part is that we have seen some phase 3B studies, and these are included data and design that cannot be reached by clinical trials, but in the prospective observational data collecting. And we have seen some bispecific antibodies in early phase trials. And we have seen some triplet regimens comparing to doublet therapies. And we have seen some selected studies, which is relevant to clinical practice, I think. So there was considerable good studies, I think. So if you want, I can make a summary of, or we can discuss some studies.
Well, maybe we could jump there. I'll ask a terribly broad question of ctDNA. Is it past? Maybe this is in other tumor types, but is ctDNA passing a precipice where it's not just about identifying underlying biomarkers, but where it's really being predictive as a correlate to outcomes? So I don't know if that's as strong in the GI space. I'm closer to it in some of the other tumor types. Mm-hmm. But what would you say to that progression of ctDNA is about identifying signals versus being highly correlated to outcomes? Broad question, but I thought I'd throw it out because you're emphasizing.
So you know the current utilization of ctDNA is we can say that. So first we can do early diagnosis and screening by ctDNA, and we can use it in the staging as a part of staging, and we can use it in the decision of adjuvant therapy, and we can use it on the detect post-operative residual disease. And we can use it in the surveillance to detect recurrence. And also we can use it to detect biomarkers and treatment targets in the metastatic setting. So in this ESMO GI, we have seen in the colorectal cancer, the ctDNA use in the surveillance part. After surgery, you follow patients with ctDNA and you try to detect recurrence early. So indeed, the FIND trial and Galaxy and Bespoke trials was presented in this ESMO GI. And these studies collectively showed that the ctDNA capture the recurrences, detect recurrences early, and it causes more metastasis-directed treatment and curative treatments. But currently, we don't know that these early detection of early recurrence and detection and doing metastasis-directed therapy could lead the overall survival benefit in future. We don't know yet. So we will wait for the long-term results, indeed.
That's fair. I appreciate that. Well, you mentioned one trial, so maybe we'll fire off picking out maybe a couple that you'd like to emphasize. I'll do my salesperson thing again and share my screen briefly. But we're really excited. One thing that we did for ESMO GI, and a lot of the conference is really busy conference summer, as one might expect. But we have been really building out this, and might be a little bit hard to see on the screen, but just pulling up briefly is that for some of our customers with Clin and some that are interested, especially in our conference planning, is that we're pushing the analytics that I showed previously in Clin a little bit further, where we're doing not just daily even alerts, meaning you'll have that sentiment of those ex post every day in your inbox during an ESMO GI or an ASCO or ESMO more broadly, but we're also synthesizing that together with even a trial rating overall that's not just AI, but it's curated by our analysts and our oncologist team. So I just wanted to flash that up on the screen. If anyone is interested in this, a little bit more highly customized synthesis of Clin data, please reach out to us. But I'm using this sort of as a springboard to, if Dr. Akkus, any particular trial disclosures jumped out to you at GI? Obviously, from the analytic in front of us, the dominant reactions were to talentase in unresectable HCC, and then obviously we had a lot of reactions to PANOVA-3 and Matterhorn. Obviously, those disclosures were more in the space of, well, at least with Matterhorn, PRO and QOL, and PANOVA as well. But I'll probably stop my selling share screen, but to loft that to you, Dr. Akkus, any particular disclosures from any trials jumped out to you at GI?
Yes, sure. We can talk about the talentase a little bit, and then we can talk about PANOVA and Matterhorn if you want.
Sure.
So,
That'd be great.
so talentase investigated in intermediate stage HCC, atezolizumab, bevacizumab plus on-demand TACE versus TACE. So it shows that an PFS benefit with adding atezo and beva. Actually, the results were consistent with Emerald trial, durvalumab's trial, and LIAP 012 trial, which is pembrolizumab lenvatinib. So all these trials now, in addition with this talentase, shows that adding immunotherapy and maybe TKI in the intermediate stage of HCC, adding to the TACE, shows a PFS benefit, but we wait for OS results in future. So in terms of PANOVA and Matterhorn, so we have seen these trials in ASCO, the survival results and efficacy results. In ESMO GI, we have seen quality of life results. So in Matterhorn, adding durvalumab to the flood chemotherapy did not cause deterioration in the quality of life. In PANOVA trial, although the overall survival benefit is modest, it provides an improvement in the pain symptoms and quality of life, which is also very relevant in pancreatic cancer. And we have seen also some other quality of life data in ESMO GI. One was the nivolumab, ipilimumab in the treatment of deficient mismatch repair colon cancer, and it's provided improvement in the quality of life, patient-reported outcomes. And also we have seen in nivolumab, ipilimumab in the HCC, in the first-line treatment, it's also provided improvement in the symptom deterioration. And we have seen also in gastric cancer, first-line treatment of gastric cancer with PD-L1 positive, sterilizumab plus chemotherapy. It's also provided improvement in the quality of life, and which is also associated with survival. So the quality of life is very important. Not adding new therapies cause some treatment burden and symptom burden. We expect to improve the quality of life, but it's also okay not to cause additional burden to the patients.
Absolutely. And just briefly, for my own edification, in terms of tumor treating fields in PANOVA, I mean, how are there other tumor types where this is being investigated, or is it more restricted to pancreatic in the context of this trial? Just for my own education, because I'm not as familiar with it.
Yes, there is some other tumors, such as lung cancer. The results, there's some conflicting results on that.
Sure.
In some trials, it's neuter. But the thing is that it's not available in every center, in every place. So it causes also some dermatological side effects. So it's currently not practiced in everywhere or beside clinical trials, as far as I know.
Well, looking at the time, we might have to have another whole podcast about the availability and how widespread or the penetration of treatment availability in this context. But like I always say, this is the shortest podcast in the world, and we can only get so far. So I think we're going to wrap it up there, Dr. Akkus. But really appreciate you coming on. I felt remiss that we didn't have a ESMO GI podcast from Onco Data. So I'm glad we were able to do that today. And really pleasure meeting you for the first time. And thank you for your time. Any last words from your side, sir?
Yes, thank you so much for inviting me. It was a good podcast for me too. I hope to meet you again.
Absolutely. I think you might be coming back around. You don't have to commit to it yet, but hopefully have you again soon. So thanks everyone for listening. We will hopefully be back on normal, maybe post-summer schedule soon. And if you're seeing this, hopefully you're well on your way to a good weekend. So thanks everybody. Thank you, Dr. Akkus.
Yeah,
cheers.
thanks so much. Bye.